Good morning, everybody, and thank you for joining us, particularly to the panel of experts that we have with us this morning to discuss the importance of having a World Patient Safety Day theme on each year. Over the last few years, we've done this, but also in particular this year, we'd like to talk about the theme for this year, which is safe care for every newborn and every child. We're very lucky to have a group of experts with us from many different sectors, and I'm really excited to listen to their views. My name is Mike Durkin, and I have a role in supporting both WHO in leading the Global Patient Safety Collaborative for low and middle income countries, but also as a supporter of patient safety initiatives in the UK and many countries overseas. So what I'd like to do is start our conversations with our panel. And what I'm going to do is ask them, I'm going to introduce them briefly, but ask them to introduce themselves in their current role. And also then we'll move into a question for each. So we're going to start with Kalipso Chalkidou, who is from the WHO. Kalipso, do you want to just say who you are and what you do with WHO at the moment? Thank you.
Sure, thanks, Mike. So my name is Kalipso Chalkidou, as you said. I'm the director of the Performance Financing and Delivery Department at the World Health Organization. And part of the mandate of the department is patient safety. Really glad to be here.
Great, thank you, Kalipso. So Kalipso, so you oversee the quality of care and patient safety programs of work at WHO. And the WHO has a huge convening power. So from a global perspective, where do you think the greatest opportunities are for improving the safety of care for newborns and children?
Thank you. I think globally, the greatest opportunities lie where the burden of harm is the highest and where solutions are already within reach, where the evidence is there about what needs to be done. So for newborns and children, this means focusing on the major sources of avoidable harm, such as unsafe birth, management of small and sick newborns in neonatal ICUs, medication errors, hospital-acquired infections, diagnostic errors, including failures to recognize clinical deterioration and surgical errors. Now, we know from studies that most avoidable harm occurs in intensive care units, especially related to small and sick newborns, and when children are receiving particularly complex medical interventions. Now, the good news is that guidance and tools already exist, including the WHO quality of care standards for children and newborns, guidelines for management of small and sick newborns, and many technical resources on medication safety and infection prevention. Now, the challenge is bridging the gap between what we know works, policy, and then what happens in practice. And for that to happen, we need tools that enable policymakers to set priorities and then ensure that policies and resources are made available to support the safe management of newborn and child conditions everywhere. It also means that managers are supported, assisted, as are health practitioners, to translate solutions into action at the facility level in their day-to-day work, ensuring that families and communities also have information to make informed decisions, but also, that's really important, the means to participate actively in the care process. Now, to address some of the most burning priorities, the WHO has identified 5 World Patient Safety Day 2025 goals, offering practitioners, managers, policymakers, and all stakeholders areas of action that can be implemented and should be implemented without delay. First, engaging children, parents, and families. Parents are the first to notice most of the time when something is not right with their child, and by listening to families, giving them clear information, and actively involving them in decision-making, we can detect problems early on and we can build trust. Children themselves can contribute to their safety when supported in age-appropriate ways. So first of all, engaging children, parents, and families. Secondly, enhancing medication safety. Children are especially vulnerable to medication errors because doses must be tailored to their age, their weight, and many medicines are not available in child-friendly formulations. There are opportunities to ensure accurate weight and age-based dosing. That's absolutely necessary to improve access to child-friendly formulations where these are available and reduce risks from off-label use, polypharmacy or dose manipulation in children who suffer from complex conditions. So medication safety, number 2. Number 3, improving diagnostic safety. Accurate and timely diagnosis is vital. Children present differently from adults, and this increases the risk of delays or missed conditions. So we must strengthen clinical assessment, early recognition of deterioration in children, and then support health workers to interpret age-specific disease patterns, whilst also listening carefully when families of the child itself flag concerns. So diagnostic safety, number 3. Number 4, preventing healthcare-associated infections. Standard precautions during all patient interactions, early recognition and management of sepsis, all essential to reduce avoidable harm. And then finally, reducing risks for small and sick newborns. As I mentioned earlier, these are the most vulnerable patients. Opportunities include ensuring safe practices in neonatal intensive care units, consistent use of evidence-based protocols, and timely interventions such as resuscitation or kangaroo mother care, team-based approaches to managing emergencies. So we're working closely with countries, particularly in low and middle income settings, to ensure the establishment of health facilities that are accessible to all newborns and their families and that are responsive to their needs, and committed to quality safety with a particular attention to the continuity of care and the transfer of care as the condition of newborn changes. Over to you. Thank you.
Thank you, Kalipso. A great entry for us. Thank you. And bringing together those five elements of this year's campaign, it strikes a chord with me because many of those elements are interlinked with some of the real tenets of failures in safety and quality of care, which are based on often a lack of transparency, a lack of exchange of information, based on hierarchy. Where is the child? Where is the mother? Where is the parents in the conversation with appropriately skilled clinicians? But often the clinicians do not listen as much as they should do. And even if they are listening, as Peter Lackman would say, are they hearing the messages about their child, particularly deterioration safety, but also respect. I think respect across the whole dynamic of interaction with our patients, regardless of age. I think you also mentioned an important element there, that this is not just a low and middle income country issue. This is a high income issue as well, based on the fact that we know that the concerns of error occur in newborns across the whole world, no matter what the setting. So thank you, Kalipso, for setting the scene for us. Sarah, so Sarah, now you've been a leader both in the NHS and now with Akeso. Would you like to just introduce yourself as we move into the role of leadership and the role of the system in terms of supporting this theme for this year?
Thanks, Mike. I'm Sarah Pinto-Duschinsky. I'm one of the managing partners at Akeso. We're a boutique consulting firm. Most of my client work is really focused on strategic change across health and care systems and the transformation of services, and follows a long career in the NHS before I moved into consulting. Thanks,
Sarah. So in the UK, we'll shift to the UK from globally. The UK currently is working on 3 shifts, if you like, in terms of their 10-year plan, looking at moving from hospitals to communities, from analog to digital, well overdue, and again, from sickness to prevention. This is a theme that has played out over many years by many leaders. Why are we spending more time on prevention? But how do you think that the NHS can make sure that these shifts don't actually hinder, but actually improve patient safety for newborns and children?
Yeah, it's a great question, Mike, because I think if you look at the themes in the 10-year plan, they're very similar to the sorts of themes that we would have seen in previous versions of a 10-year plan from 10 years or 15 years or 20 years ago. And I think, there are, some interesting challenges for the NHS as to how we enact those changes. How do we make change happen more effectively and at scale? I think it's hard to argue that the 3 shifts themselves aren't good things. I think we'd all agree that a larger focus on preventative care delivered closer to home and being digitally enabled in the way that we run so much of our lives now, that isn't an ambition that we should be really comfortable with. But I do think there are some very important enablers to protect and improve safety along the way for everyone, but particularly for newborns and for children's services. I think the first of those is about data. If you don't have visibility, if you don't have transparency of the data that you're collecting, it is very hard to understand what impact you're having, to make the right decisions. I think that is a lot more holistic than the league tables that we've seen introduced or reintroduced again this week in the UK. How do we bring together quantitative and qualitative data to give us a much more holistic view about the experience of care, not just a raw set of numbers? How do we produce more of that data in real time so that we can make timely decisions? And how do we interest leadership across the NHS in what that data is saying? I know when certainly I was working in NHS England, Secretary of State would have on his whiteboard in his room a list of the never events across the NHS in that week. Now, you can have a range of different political opinions about what the health service was doing at that time, but it said something very, very important to me in the room with him and to the wider service that data was there. It wasn't the waiting time data, it wasn't the A&E data, it was the never events. And I think we've lost some of that focus. Second key enabler is around the pace of change by which we enact the 3 shifts. As we shift services into the community, as we put more of our money into preventative services, we need to do it carefully. We need to think about how we don't destabilise services in other parts of the NHS system, or indeed the public sector system. And I think we lose some of that debate in the 3 shifts about, if money is going into the NHS, what other things in public services that also have an important safety focus do we potentially not fund in the same way? How do we make sure that the financial incentives and the other incentives that the NHS can use are lined up in the right way so we can really manage the pace in a way that maintains and improves safety? Third thing I'd say is around engagement. The 3 shifts are not ends in themselves. The service models that encompass those 3 shifts need to be developed and enacted with the ongoing voice of citizens, patients, families, in the way that we develop the new models of care, the way that we make the changes happen. I think the next enabler I'd raise is about honesty. One of the things that really struck me as an NHS chief executive was the reticence to recognise safety concerns or to recognise the fragility of some services that could then lead to safety concerns. And that when you bring services forward to reconfigure them, every reconfiguration I've been involved in, there has been an easy political answer to say, just reinforce what we currently have, put more money in, put more workforce in, keep it as it is. And the reality is we cannot either afford to do that, or we haven't got the staff to do it, or it's not the right thing because services have moved on and technology has changed and we can do different things. But we seem to have concern about bringing safety to the fore and making it a key tenet behind why we need to make some of these decisions. And I think we need more openness about what we need to do. And I think that's particularly important given if we make the 3 shifts happen to the extent that the 10-year plan sets out, we will need to make change within the hospital sector. And we need to be honest about that, because if we can be honest about it, we can plan for it, we can come to an agreement about what those changes need to be. And I guess that takes me to my final enabler, Mike, which is about behaviours. Leadership behaviours, whether that's clinical leadership, whether it's about local leadership and the way that we drive change with partner agencies, whether it's about the leadership from a clinician engaging with a family in front of them, whether it's about national leadership with a Secretary of State, we have to have the behaviours to pilot new things with some proper safeguards around them. We need to be prepared to learn quickly about what's working. We have to be prepared to stop things that aren't working properly. And we need to be able to share what works and really focus on spreading good practice as quickly as possible. And without that behaviour, without those leadership behaviours at all parts of the system, I don't think you can be really certain that you can make change happen in a way that promotes and improves safety.
Sarah, thank you. Great words there. And let's hope we can bring some element of action and implementation into those elements. You've reminded me of a time probably 15 years ago now, certainly 10 years ago, when we set up a process in England of patient safety collaboratives across all the health science networks. And at that time, we had a lot of time to think, and the system produced a template of priorities for improving safety across the NHS. I'm not going to go into the priorities, of which children was a top priority for safety, but the cardinal, if you like, the cardinal priorities were that of measurement and leadership. And without those 2 being the core priorities for everybody, everything else underneath that started to dissipate. And that was reminded to us by Don Berwick when he came to lead a review that Jeremy Hunt had instigated into the safety of patients across the NHS in England. And he was ably supported by Lucian Leap, who was at the time, if you like, the leader, who also talked about leadership as being a core element, but courageous leadership that didn't shy away from admitting mistakes and also supporting people when they made a mistake rather than hounding them when they made a mistake. So, Sarah, thank you. Lots of great ideas there for us to move on to. Philippa, can I move to you? So you have a difficult role in terms of leading investigations and leading the system within HSSIB. For those listening, can you just explain who you are, but also what is the role of HSSIB at the moment?
Yeah, thank you, Mike. So, yeah, I'm Philippa Stiles, Director of Investigations at HSSIB, which is the Health Services Safety Investigation Body. We have a team of safety scientists and experts in investigation, and we can investigate any safety issue that occurs across health and care in England, in the NHS, and in independent healthcare as well. And we look at those systemic safety issues and use safety science to understand why those incidents happen and what can be done to avoid them happening again.
Right.
Earlier,
yeah.
Sorry, go on.
No, okay, Philippa, sorry, you keep going.
I was just going to come on to the work that we're doing and again, kind of investigate a wide range of safety issues, many of which impact on newborns and children and their families. Earlier this year, we started to scope some work in relation to maternity and neonatal services, primarily because we continue to hear about the avoidable harm and sadly, in some cases, tragically, deaths of people receiving care in maternity and neonatal services. So we felt it was only right to explore that. And throughout any scoping work for our investigations, a key activity is engaging with people who have experience and expertise and lived experience of whatever that safety issue might be. So in this case, we engaged with a significant number of national stakeholders, patient advocacy groups, campaign groups, people who are very close to the detail of what happens in maternity services, but also to women and their families, as well as clinical and policy leads and staff working in those services as well. And as I've mentioned, we reviewed all of the concerns that have come into HSSIB. The majority of those are from women and their families around their own experiences and treatment, but we also receive concerns from staff working in those services and their experiences of trying to deliver care in what is a really challenging environment. So we already knew, and our work has confirmed again, that the multiple streams of work that happen in this space, the various different types of investigation are incredibly complex. And for those trying to address those safety concerns, it can just feel overwhelming. So when the Secretary of State announced earlier this year that there would be a national maternity investigation, we felt it was only right to pause our work. We didn't want to add to that complexity or confusion. But in the relatively short time we had done that scoping work, we knew there were some key fundamental messages that we needed to share, both with everybody working in the system and people experiencing care, but also to try and support that national team doing the investigation to understand where we think they should prioritise their efforts. So as I've mentioned, HSSIB used safety science to explore those systemic issues which can contribute or cause that harm. And we also, kind of linking back to somebody's comment earlier, we really consider work as done versus work as imagined, because we know there can be a significant difference in those two spaces. And in maternity services, sadly, we have and continue to see avoidable harm and tragically deaths. And we know that unless we really understand and address those systemic issues, sadly, we will continue to see the whole system firefighting all across the country. So following analysis of our initial scoping work, we identified 4 key areas that we think are contributing to or causing harm. And that includes compounded harm for women and their families, as well as staff working in the services. And obviously that is compounded when things sadly go wrong. So those 4 areas, the first being the national structures that are responsible for providing direction and oversight of maternity services, the local governance arrangements and their relationship to national bodies, which can mean they often operate in isolation, the standard and approach to local investigations when things go wrong and what it's like to be on the receiving end of those, and the education, training and professional standards that support clinical staff, particularly when they enter this profession. So many themes were identified during the work that sit under those 4 key areas, and we want to ensure it is noted that some improvements have been made in maternity and neonatal outcomes, staffing and governance arrangements. But sadly, we recognise there is still limited potential to really learn from harm, which we continue to see. So I just want to touch on a few of the key issues that were identified through our work. So as I've mentioned, the national infrastructure is overly complex and often poorly coordinated. There are national efforts to collaborate, but sadly they are inconsistent and variable. We continue to see far too many recommendations. I don't think that's just in maternity, but it is significant in maternity. And those recommendations, there is often limited, if any, in some case, implementation. Individual services still struggle to identify and respond to clinical risks. There are clearly inequalities and disparities in care and outcomes for people using maternity and neonatal services. And as I've mentioned, concerns about educational pathways. The other aspects that came through really loudly and clearly, and this links to how local investigations and national investigations are undertaken, is the compounded harm caused to women and their families who are seeking answers to what went wrong for them and their families, and either can't get them or are treated in a way that puts them in an incredibly difficult and traumatic space and continues to cause that compounded harm. Sadly, we know for not just a short period of time, we are talking years and years and years here. So our summary, that report is available on the HSSIB website. I'd encourage people to have a read. As I've said, we really hope it will contribute to the work led by the national team at the Department of Health and Social Care to inform their work. And just picking up, we do other work in relation to newborns and children, which I think contributes to this discussion and the priorities for keeping newborns and children safe. So we have published reports into how we keep children and young people with mental health needs safe. So looking at things such as the design of paediatric wards. Picking up on your comment earlier about medication-related harm, we have done a series of investigations looking at medicines and are currently doing some work looking at the administration of insulin, which obviously affects a lot of children and young people as well. So really keen to engage with the conversation today and see how HSSIB can continue to work in this space.
Thank you, Philippa. Thank you. Certainly that almost series of issues that you identified. I'm always keen to think about mathematical models, but those series are also run in parallel, and they run in parallel in many different systems across the health systems across the world. So the examples that you brought out about what happens in the UK is not unique to the UK. I would suggest, and I think therein lies one of our challenges in terms of a global movement for safety that the UK has always played a key part in supporting WHO over many years is that we start to learn from these in-depth investigations and use them not just to change the way we work at home in the UK, but also in overseas systems. Often the most challenging ones being those high income systems who rely on extant hierarchy. But I won't go on to that because that's a hobby horse of mine about how hierarchy is the enemy of safety.
And
sorry, Philippa.
Just to say, Mike, I could see everybody nodding as I ran through that list of issues. And I think if we're honest, none of them come as a surprise. And none of them come as a surprise to anybody working in these services across England, but across the globe. But actually what we're not doing is taking the time to really understand why those issues are so persistent and continue to cause avoidable harm and coordinating our efforts to really address them.
Yeah. And so this isn't a plug for Kalipso or for WHO, but it probably is. The Patient Safety Action Plan is a core document that breaks down a whole series of strategies about how we can address some of these elements, of which a consistent one is implementation. And what is the science of implementation? How do we really change what we're doing? Not just understand what we need to do, but how do we need to do it? Maybe a conversation for another day on there. Can I move on? James has been patiently waiting in the background. James Titcombe, for many of you who will be listening, is known for his work because of his personal journey with the concerns over the health offered to his wife and his son Joshua, who was sadly lost to him and to the rest of us. But James has built on that and also his understanding of safety science from his own background, and is now both an activist, a change agent, but also a considered commentator on elements. So I think we're very lucky to be able to have you with us, James, this morning. James, after you introduce yourself, do you want to just, and the work you're doing, but one of the elements that you often talk about is the concept of restorative justice, which is a key element, I think, to introducing a culture of safety at every level. So could you also explain what this concept means and why do you think it's so important, particularly in regard to newborn and childcare? And we've also already heard of this compounded issue that Philippa has raised for families. So first of all, introduce yourself and then into that area of discussion. Thanks, James.
Thanks very much, Mike. And I think your introduction there was very generous, and you've covered a lot of the key issues. So just firstly to say, this theme of World Patient Safety Day this year is really personal and very relevant to me. As Mike, you were saying, in 2008, my journey into this kind of area of patient safety started with very tragically losing my son. And actually the main failures that happened were after my son Joshua was born, and there was a failure to respond and recognise neonatal sepsis. So it was very much the care in that 24 hours after he was born that led to the failures that led to Joshua's death. And Philippa, what you were saying about the themes you've identified really resonated with me, especially that listening to families and their concerns. So that's how my journey started into patient safety. I now do a variety of different things, probably just highlight a few. So my main role is working with a charity called Patient Safety Watch, very small charity, and we commission research into the causes of avoidable harm, working with Imperial College London, and kind of publish an annual report. And very briefly, I also work with a wonderful charity called Baby Lifeline, that's a very good charity that supports maternity safety, and an organisation called the Harm Patients Alliance. So that's basically me. And I think Mike, my initial focus after Joshua died was very much on promoting a culture where we can learn and improving investigations. And more recently, you're absolutely right, I've kind of focused very much on what we call restorative practice. And picking up from what Philippa was saying, really, this idea that when things go wrong due to unsafe healthcare, there's the impact of what happened, and in Joshua's case, the impact of losing a baby. You can all imagine it doesn't get much worse than that. But I kind of honestly reflect to people and say the way the system responded afterwards really made it very difficult. And I would probably go as far as saying that the system response, so the way I dealt with all these complex systems and the way the system treated me, was almost as harmful as Joshua's death itself. So in more recent years, I've been very focused on this area. And in 2021, I set up a little organisation called the Harm Patients Alliance. And that was working with a wonderful colleague of mine called Joanne Hughes, who some of you may know, but Joanne is also a bereaved parent. And Joanne really has been the inspiration for this and become a bit of an expert in what we call restorative practice. But very briefly, restorative practice, it kind of originates from other settings, so particularly the criminal justice setting. And what it's really about is recognising that when harm occurs, there are needs, and in healthcare, this relates to patients and families and absolutely staff. And if we apply the kind of principles of absolutely the imperative when something goes wrong is learning, we all accept that, but we also have to help people heal and recover. And restorative practice is a great framework that allows us to do that, mainly through listening to what people's needs are, making sure that the process doesn't create compounded harm, so compassionate engagement through investigations, but also really listening to what people's needs are, deciding whose obligation it is to meet those needs, and really providing that kind of caring and compassionate support. And just to mention specific projects that we've been running in that space, so working with a charity called Action Against Medical Accidents, AVMA, we've kind of developed this thing we call the harm patient pathway. And what that is all about is encouraging organisations to say, you know, when somebody's been harmed because of unsafe healthcare, absolutely focus on learning, but also have things in place that are going to support staff and families affected to heal and recover. And that pathway project, we're really pleased because it's had some traction in England recently. So in the Penny Dash review, it was kind of mentioned as an example of, you know, where we need to go. And in the recent investigation into maternity services at Swansea, Mike, it was recommended as something Wales should consider implementing. So yeah, very much a focus is the need, I think, to recognise that when things go wrong, we could be doing a much better job in healthcare of paying attention to people's needs, staff and families, and really helping people heal and recover. So yeah, thank you.
Great, thank you, James. And again, there's a resonance there with the words from Peter Lackman of the need to really understand the position of the mother and the father in where they see changes in their children, no matter how small that baby could be. And this was borne out, I think, probably in the work that has led to Martha's rule in terms of really identifying that we all have a responsibility as clinical professionals to listen to not just the parents of the young, but also the carers of the old, who often know their loved ones better than we would do as a visiting, if you like, as a visiting interested clinician. So thank you very much for sharing that, but also thank you for all the work you're doing here and elsewhere in terms of supporting all professionals, but also supporting families when things have gone wrong. So thank you for that.
Mike, I would just
yes,
absolutely sure. Just to echo those comments. And in the 24 hours after Joshua was born, I think especially my wife, a real instinct that something wasn't right. And I think particularly in a healthcare setting, families can feel quite disempowered, almost as if, you know, that the experts are the professionals, and we don't want to question their judgment. But actually, if we get this right, families and patients, and loved ones need to be part of that care team, and actually their insights and their instincts need to be considered really with as much credence as clinical observations. So Martha's role, which you've mentioned, is a very, very important initiative, and I think there's early work being done to roll that out in maternity services in England, which I think is really important. So just to agree with that.
Yeah, thanks, James. Yeah, certainly across many sectors and systems in the world, you often see the impact of hierarchy through gender or through race or through religion, but we often run away from trying to challenge the hierarchy of expertness, and it's that hierarchy of expertness that often undermines the relationship between patients and their clinicians, but also families and their clinicians. Right. Thank you very much so far for your time. I just want to spend the next 5 minutes or 10 minutes, if we still have time. I think we have a little bit more time. Just really asking you, each of you, with so many pressing patient safety issues, you know, you look at every sector and there's issues in every sector. And we mentioned some of the themes in this year's theme about medication safety, about communication, about infection prevention control methodologies. With so many different patient safety issues, why is it important that we need to prioritize newborn and children's patient safety? I mean, why them as opposed to others? I'd like to go in reverse order, if you like, now. So James, why should we? Because you're also an advocate for other sectors as well.
Absolutely.
Groups.
I I think there's a few points really, and I think the start of life is such a critical period, isn't it? And you know, newborn babies and children are so vulnerable. And you know, when I think about my own case, Joshua couldn't advocate for himself, and I think newborn babies and children obviously can't advocate for themselves. So having a safe system, really, it's a moral and kind of societal imperative, isn't it? And also, I think the harm that can occur at that stage can be profound, and it can last a whole lifetime, you know. So it really is a crucial time. And what I really, you know, just to draw attention to this, so as people have mentioned, in the UK, the Health Secretary has got a very sharp focus on maternity safety at the moment. And what he said, I think, was very powerful when he was talking about the reasons for this. And that's almost maternity services, neonatal and child care can almost be seen as a kind of a litmus test, because if an organisation isn't getting it right for that really vulnerable group, is it going to be getting it right for other areas of the organisation? So I think seeing maternity care with that most vulnerable, neonatal care, paediatric care for that most vulnerable group, if we're getting it right for them, I think it probably is a good litmus test for wider safety. So that would be what I would say, Mike. Yeah.
Thanks, James. Philippa,
Yeah,
focus for HSSIB. How can you influence this, and why is it important to prioritise the newborns?
Yeah, completely echo James's reflections and comments. And at the end of the day, every baby born across the world has a right to life and a right to be kept safe. And we have a societal responsibility to do that. They cannot do it for themselves, and they are extremely vulnerable. And also, when things go wrong, that trauma is so significant, and will impact them for the rest of their lives. And actually, we need to ensure that babies and children are kept safe, have a positive start to life. That will give them a positive trajectory in terms of keeping them healthy and having a fulfilling life. And also the ripple effect that has, and the impact that has on the health and the lives of their families. So and also, just picking up, Sarah mentioned earlier, thinking about kind of that wider holistic aspect of keeping newborns and children safe. We have to work in partnerships with other parts of society, the judicial system, social care, education systems, because the risks and the impact on newborns and children and their health doesn't just sit in a hospital. It sits in the community, it sits with other services, it sits with other professionals that they will interact with and their families. And if we get this right, as James has said, if we get this right, that's a fundamental shift in the health of our society. When we get it wrong, the detriment is really significant.
Thanks, Philippa. Wise words for us to move on from. Sarah, you mentioned the core aspect of leadership as one of the themes, I think, in your answer. How do you influence leaders across all systems? I mean, there's the UK, but there's the rest of the world, as you said, who have common issues.
Yeah, I mean, I think this point about learning that a number of us have talked about, I think we need to encourage, and certainly from a UK perspective, we need to encourage the NHS to come out of the NHS bubble. I mean, it's hard enough sometimes to get parts of the NHS to learn from each other, but helping the NHS learn from good practice, from evidence being accrued in other parts of the world, I think is really important, because I think as a system, as a society, we will be better for being more porous about where we take our knowledge and best practice from. I think, just looking at though, I guess how do you build that case for change for leaders? I think there's a very logical set of steps that an argument that you can build around the downstream impacts. How much money does harm cost us within the NHS, within UK PLC? It's a huge amount, and not just in terms of the sort of compensation. It's also the downstream impacts that it has on the life trajectories of the children, babies, and the families involved. And so much of our political discourse at the moment is around opportunities to help with the, you know, economic contributions. How do we as an NHS play into helping the country grow the economy? And this is, I would argue, this is a really fundamental plank in that economic growth. I think, though, if I think about the NHS leaders that you know, I work with, I talk with, that I've, you know, built a career with, I've always passionately believed that what makes the NHS and makes healthcare systems so special is that they touch every single person in our society, and they touch those individuals at the periods where we are most vulnerable in our lives. That is why I get out of bed every day to work in this sector, and that's why the colleagues that I've worked with before, you know, that's what motivates them. And I think there's a really fundamental question for us. If we can't be bothered to make services safe for children and newborns who depend on us, then what does it say about us as a society? Because surely there is no other group that demands us to lean in and support them than those who struggle and cannot advocate for themselves.
Fine, thank you, Sarah. Thank you. I think we have failed consistently in terms of bridging that gap between the financial business case for quality and safety improvement and the impact of the harm itself. And we've failed to engage directors of finance, chancellors, to really shift that paradigm.
I think that's right, Mike. And I would say, I think it plays the other way as well. I think, you know, we talk a lot in leadership about what's the role of the board. How do you sit around that table as a board member, not as a professional leader for, you know, doctors, for nurses, for finance. And I think we absolutely need to be encouraging boards to consider this as a collective responsibility and understand the trade-offs that you're then making when you start looking at your annual cost improvement program, your service configuration. And you know, we need to be encouraging ourselves to have those conversations.
Thank you, Sarah. Thank you. I know we're really tight for time. Kalipso, you have an enviable role now in terms of leading this sector, really, for WHO on safety, amongst other roles that you have. Why do you need to prioritize it, and how are you going to do that?
Thank you. I mean, patient safety should never be treated as an optional extra or a competing priority, right? Safety has to be understood as a foundational prerequisite. It's a precondition for delivering care to everyone in every setting. The fundamental principle of clinical care is first do no harm, so we have to stay loyal to that. Now, why, you asked us, Mike, why newborns and children? Well, newborns and children deserve particular focus because they face higher risks due to their rapid development and their evolving health needs and the different disease patterns. And as James and others said, they rely on us, they rely on adults to speak up and make decisions for them. At the same time, children are way more vulnerable and faced with additional challenges depending on their socioeconomic circumstances. And these factors make them more susceptible to harm if care isn't adapted to their age, their size, their condition, their social and socioeconomic context. And again, as others have said, when harm does occur, the impact can last for a lifetime. Sarah talked about the economic case, you did too, just to give you a figure. Just the direct costs, and of course the indirect costs are also significant, but just the direct costs in developed economies are almost 13% of total health expenditure, approximately $880 billion US annually. And this is a really large figure, especially in the current climate. So there is also this economic case which has to be made. 62% of neonatal deaths are due to lack of quality care. So improved quality of care can save up to 1 million newborns. These are really mind-blowing figures that I think should really push us to act. prioritizing safety for children is essential for achieving universal health coverage. It's essential to the principles of the National Health Service and the principles of the World Health Organization and all our member states. And you mentioned the UK being a major member state, a major voice on this agenda. We're very grateful for that. We can't achieve the Sustainable Development Goals, the health-related SDGs, and the target on child survival, or deliver on the promise of universal healthcare coverage for all over the world, if families fear that seeking care may put their child at risk. So putting the safety of newborns and children at the center is the clearest way, it's the only way to measure whether our systems are truly safe. We can't afford to fail on this agenda, and we must really try and keep our promise of health for all through fighting for patient safety and for child and newborn safety. Thank you.
Kalipso, thank you. I think that's a great way to finish. Thank you so much to everybody. We all need now to go back to our workplaces and institute these changes, implement where we can, and influence others to implement where we can. As Kalipso closed with, many lives are lost unnecessarily through avoidable issues. This costs our system inordinately and prevents then reinvestment in support. So we have all a responsibility to change and improve. And as Sarah said, learn. Can I thank you all for such a great conversation and a good dynamic between us. And I hope I see you all again in the near future. But for now, thank you very much.
Thank you. Bye-bye.
Bye-bye. That we're having today regarding the theme for World Patient Safety Day 2025. Now, Peter, you're known as a educator, an activist, a leader in patient safety, but you're also a skilled neonatologist and pediatrician who's led many changes in your own field across the world, notably while you were a consultant here in the UK. Why is it that we need a World Patient Safety Day, particularly with a theme on safe care for every newborn and every child? One would have thought that was axiomatic to the care that we offer our children and newborns across the world. But why do you think it's important that we celebrate a theme for this for the year?
Well, thanks for asking me to this webinar web chat, Mike.
Yeah.
So let's just put it this way. I trained in South Africa where I did my neonatology, and then I moved on from neonatology and general pediatrics to become a child developmentalist. And most of my business were the results of what happened in neonatology, and when things went wrong, or particularly in obstetrics, where there was an early intervention and you had hypoxia, or you had placenta previas, or you had some kind of problem coming on and the baby was affected. Now, the future of any society starts with children. Yeah. And to me, the most important thing in healthcare is maternal and child health. If you had to say where would we have to invest, is maternal and child health. It's quite straightforward. And where do you want to invest for the future? You have to invest in children. I think say that from a medical point of view, I say it from a moral point of view, and I say it from a human rights point of view. The UN Convention of the Child quite clearly states on Article 24 that it is our duty to provide good healthcare. It doesn't say safe healthcare because it was before the safety movement, but it's implied that you should have good healthcare, and that governments have the duty to do that. And we as healthcare providers have the moral responsibility to provide good healthcare. So I started from that point of view, yeah. that it's a human right, and it's a child right as per the UN Convention. Often now it's quite strange because the UN Convention is not even thought of that nowadays. Previously, we used to have people used to do audits on countries of whether they apply in the UN Convention. That doesn't seem to happen anymore. Because if it did happen, most countries would fail.
Yeah.
And if we started to look at healthcare, most countries would fail. Because as we sit in here right now, children around the world, upper and lower income countries, are being affected by unsafe care. And
so you think, so sorry to interrupt, but see, this is not just an issue for low income countries then?
Oh, no, no. If you just look at the Imperial College report from last year on maternal health,
Yep.
and on child health, the number of deaths, maternal deaths, is going up, and the number of child deaths is going up. And even worse, it is related to who you are and where you're born and where you live, the social determinants. So it is not only a health issue, it's a political and social issue. So this year's theme is probably the most important theme. They've had maternal and newborn before in about 20 or 21, I can't recall which one. They've had it before,
Yeah.
but this time it's really specific that the future of society depends on what we do with our newborns and children, and they are the most vulnerable. Likewise as the elderly. The elderly at the end of life are very vulnerable, and the children at the beginning of life are very vulnerable.
So Peter, one of the themes for this year's campaign are based on raising global awareness of safety risks in paediatrics and newborn care, mobilizing governments, healthcare organizations, all professional bodies, but significantly empowering parents, caregivers, and children themselves in patient safety by promoting their own education and awareness, but also advocating for improvement in research in this field. When we think about some of the cardinal elements of safety that are consistently we fail in across every nation in the world, they're those of transparency, of engagement and communication, and respect for the patient, and also respect for other members of the caregiving team, to break down some of the hierarchies that exist. How do you think we should play that out through this, particularly with the relationship between healthcare staff and children and parents?
Well, you see, it's a very strange thing because pediatrics attracts a certain type of person, and the pediatricians say we love children, we like them, but there's still this hierarchy. At the end of the day, the mother knows the child best. The mother is the expert, not the pediatrician. The pediatrician is the expert in childhood disease. The mother's the expert in the child that she brings to the expert in childhood disease.
Their child.
Their child. And what I call, or Chris van Hecht came up with me, so it's from the literature, the moment of truth. The moment of truth is where these two come together, these two experts, one the expert of clinical issues, and the other is the expert of her own child. They come together and they share information and come to a shared understanding of what the problem is, and then come to an agreement. Now, this is often called shared decision making, but it's quite a complex situation, because what it does mean is that the clinician who has been taught about the hierarchy or to live in a hierarchy now has to have an equal point at that point. And sometimes the mother is more right than the clinician. But there's one thing for sure. When it comes to deterioration, the mother usually is always right. And if the mother raises concerns, you have to take it seriously. And this is about deterioration. I could talk about many different areas, But really, around the world, what we have is a very hierarchical system. Now, the hierarchy, just to say, it's not something new. It's historical.
Yeah.
It's historical because if you look at the history of medicine, the doctor had a particular position, or the health provider in society, alongside with the priest, the religion, the two side by side.
I can always remember. I can remember in my own training, the pediatricians would try to suggest that we shouldn't listen to the parents because I can still remember that day.
Not only must you listen, you must hear. So you must listen to what they say, and you must hear what they want you to hear. And then you come to a joint decision. Now, in patient safety, see, in the patient safety, we have gone down many rabbit holes, You might wonder why in 2025 we are having this discussion about unsafe care and about how things could be safer. You may wonder, why is it that in the highest risk area, the very highest risk area of all medicine, which is in the labor ward, which is in the delivery of children to life, why that's the highest risk area, why it's not 100% safe or mitigated against safe? Why aren't they using human factors in everything they do? Why aren't they doing simulation? Why aren't they acting like in a high reliability organization, practicing all the time for every event, day in, day out practice, rather than just delivering service and training people on the job? I mean, which other industry would train people on the job in the highest risk area? And the highest risk area is mothers having babies in the whole of healthcare. And how I know it's the highest risk area? Because you go to MDU or you go to the claims agencies, that's where the biggest payout is in the whole of healthcare. The NHS, that's the biggest payout. And that is the highest risk area, yet we still have people being trained on the job.
So in terms of trying to not just ameliorate, but eradicate error, which is a real challenge, are there any tools or techniques that you think should be adopted that we're not adopting, or any elements of, you mentioned high reliability, how do we introduce that into a system?
Okay, so the problem we have in patient safety is we've got all these theories. The thing is in patient safety is that over the past 25 years, we've made great advances in the theory, not so much in the practice. We know what to do. The problem is the implementation. Now, one of the problems of the implementation is that patient safety is seen as an add-on. It's not as seen as what we should do. And the kind of message I'm saying right now, it needs to be in our genome, in our DNA. It mustn't be something that we think, oh, now I need to do patient safety because there's been an event. Rather, one's always asking, am I being safe? Are my practices safe? What is going right and what is not going right? And how can we fix it in real time? People say we're too busy to do this. No, it's not. That's not safety if you're too busy to be safe. Yeah. So we really got to start changing the name of the game. And I think that starts in medical school. It goes through your training. It's woven through. It's not an additional subject that you go and have a lecture on human factors and now you've done human factors. No, every time you see a child or a neonate or in the obstetrics unit, every time you are asking about safety, every time. And that's where the leaders have to do it. But the problem is the leaders haven't been trained. So we have to really reinvent ourselves so that it becomes what we do.
And this is relevant to every profession in all the clinical professions. It's not just the doctor.
No. It's everyone. I'm picking on children on the highest risk areas. Is that patient safety needs to be what we do all the time. And to do that, people got to be talking about it all the time. So, for example, the SAFE program with a situation awareness for everyone is designed just like that. So what we
that's
do,
safe situational awareness for everyone.
everyone.
Safe.
So situational awareness means that everyone is on the same page. The nurses, the doctors, the parents, the cleaners, the dinner lady, the teachers, everyone's on the same page as who's the sickest child is, who's the child who may fall, who's at the highest risk for medication harm, whatever it is. They're on the same page. In the obstetrics units, who's the highest risk of PPH, who's the highest risk of obstructed labor. Everyone knows, and then they're going to say what we're going to do about it.
Yeah.
And so everyone's talking about safety the whole time. That's what they do in high reliability organizations. That's what they do in aviation. Now, we're not flying aircraft, but what we can do is start talking safety. We don't talk safety. Every day, this first question that an attending or a consultant should say, what are the safety issues today? Who are the highest risk neonates? When I talk about in the goals for the year, we chose five goals, and the goal number one was, the first thing is engage with the parents, because they'll know who the highest risk is.
Yeah.
So that's goal number one, and worked with Helen Haskell on that, and we made sure that we put in goals that are achievable, so that people can really start talking with parents, not to parents, and listening to them and hearing what they say and adding that in the assessment. Then the next one is medication safety, because that is the highest risk for children. Remember, medicines are made for adults, and in children, it's all dose related and weight related. So you've got to know the weight and you've got to do your doses, and it's very easy to make mistake. But of course, we don't give prescribing high enough priority within our workload. So what happens? Doctors do it while they're talking about the football, the rugby. They get distracted. They don't have the BNF, and they make errors. Application and transitions, very big areas. So prescribing.
And we know from our national reporting system and schemes that medication, not just prescribing, but dosage and dispensing are where the errors occur.
Sure. And I can't believe it that we talk, and people say, oh, we'll put in electronic prescribing. No, electronic prescribing doesn't work if you don't have a culture of safety. Yeah. You have to have the culture of safety where you're talking about safety every time. And one of the things is you may have been involved in the double checking, nurses doing double checking.
Mm-hmm.
I thought that was an insult to nurses, because we never said doctors have to be double checked.
Yeah, exactly.
I mean, I don't know who said it. How could they say something where they said, okay, it's the nurses the problem, not the doctors prescribing badly, and that's the problem. Doctors prescribing badly.
Yeah. One of the greatest changes, or the most successful changes, is adding a trained pharmacist on the ward to guide not just the nurses, but especially the doctors, the junior doctors in particular.
My take is that the prescribing in a high risk area is not the role of doctors. The doctors say this is what needed, and the pharmacists do the rest. And I know it's not possible because of the lack of pharmacists, but this is where we have to do. And if you add prescribing pharmacists to a unit,
you reduce error.
You not reduce, you eliminate error. There's a difference. You eliminate. So medication is number two. Number three is very important. It's diagnostic error, and within that is misdiagnosis, wrong diagnosis, and delayed diagnosis. And within those are sepsis. So Martha's rules came through. Now
I was going to ask you about Martha's rule and your thoughts about that.
Martha's rule is very sad, because why does Martha's rule need to come in 2025? Because they didn't listen to parents. They didn't listen to Martha's mother and father. That was the problem. And I had a similar case before I learned about patient safety. 4 cases. I had 4 cases, and I mentioned one on the other webinar, but I had 4 cases in 2 years where I sat with parents as the clinical director, had to explain to them that we had watched their child die. And they said to me each time, why didn't they listen to us? We said there was something wrong. And these were very good pediatricians. I couldn't drop. They were very highly performing pediatricians, but they weren't hearing what the parents were saying because the vital signs were normal and the cliff hadn't been reached yet. It's only when the cliff is reached and the child falls off the cliff, and that happens in sepsis.
Yeah.
And so that's what happened with Martha. She got to the cliff and then it was too late when they tried to rescue. So this is the whole problem with delayed diagnosis and misdiagnosis. And I think that as we're sitting here and we're talking from England, there are children who have been delayed and misdiagnosis right this second. The fourth one is infection control. That's the second biggest one of the top three: diagnosis, infection control, and medications. And that one, we still have problems of infections that we can conquer. We can do that. In fact, that's where we've had the most success with. At Great Ormond Street, we virtually got rid of central line infections just by including human factors in that. And you can really do that. So that's where we've had the most success. So there we can really make a big difference. And for example, in neonatology, one of the best ways to do it is kangaroo, by putting the baby to the mother's breast straight away. Because the final one is the newborn. We have a special one just for the newborns, and it incorporates all the ones above. Because for the newborns, it's a special one because they are at the very highest risk. And then look at lower middle income countries, very different scenarios to upper income countries. For example, I work in Mozambique, and in Mozambique, one intensive care for the whole country, neonatal intensive care for the whole country. Can you imagine that? So what do they do in other hospitals? You can give them advice, which is in the fifth goal, that even other hospitals that don't have intensive cares can apply to try and keep them. The best one is kangaroo for any baby, and they can do the kangaroo put on the mother's breast. And there's firstly, you're getting good bonding, and secondly, you're decreasing the rate of infection, and you're giving the baby colostrum very early on, which decreases infection. So there are many good ideas in there, but you can say, why are these 5 goals important? Because if we do that, we're going to save lives.
Yeah. Okay. Thanks, Peter. Thank you. We've taken up a lot of time from you already, but can I just, my final sort of question really, or discussion point is, who is responsible for making this happen? And who or what? And I'm trying to think about, how do you create a global momentum that becomes everyone's responsibility? Now we speak very glibly about that, saying we're all responsible for change. But have you got any thoughts about how we take this forward on with a global momentum?
So I think we're at a kind of a tipping point right now, and I can say this for this. Firstly, at a global level, the WHO. Okay, so the global level WHO talks to the member states, and that they're talking mainly to governments. They don't talk to frontline staff. They talk to governments. The role of governments is then to talk to their ministries of health. Their ministries of health talk to the healthcare providers. So that's still going down. So that's very important. But what's more important is that the International Pediatric Association, and I chair now co-chair the Quality and Safety Committee for that, have committed to these goals and to this year, which is a big way forward, because they have over almost 150 societies around the world who belong to the IPA. And the IPA is now saying patient safety and quality is very important, which is new because I've been working with them for the last few years, and we started about 3 years ago where it started coming onto their agenda. And so that's a tipping point for me, that's happening. And I can just give you an example just in the UK for the college, at the College of Pediatrics. We now have a patient safety portal. We have a lot of tools. SAFE program emanated from there. And if I look at where the college has come over the last 15, 20 years, it's a major, major change. I gave a keynote address at the plenary this year, which is something that never happened before. So the key thing is there's tipping points happening right now. And what was quite clear to me is that people are starting to do it. But where it really starts, Mike, is with education, is that the medical schools have now got to take it up and say, look, we should have in our medical schools a professor of patient safety and a professor of human factors. There should be a department of patient safety doing the research, very important. Yeah. And then every medical student, every nursing student should have patient safety woven into their genome. Yeah. Just like you can't do medicine if you don't know physiology, pathophysiology, anatomy. You can't do medicine any other way. Yeah. So just like that, you cannot do medicine unless you know human factors, unless you know how to engage parents, in our case, parents and families, unless you know how to communicate, you know how to work in teams. And this must be woven in from day one and must be part of your training all the time. And that will make a difference.
Thank you, Peter. Thank you. So you've got me on to thinking also about how in the UK, therefore we can influence NIHR for more research in this field to produce more appropriate answers to our questions. But also, how do we influence, and how will we influence nursing councils, medical councils, as well as our colleges to keep on this work. Peter, thank you very much for giving up your time. I know you're traveling between, as always, you're always traveling, but I know you're on a plane very soon. So thank you very much for giving us your time and your thoughts. We know that you'll continue to advocate for change and improvement on patient safety in general, but neonates and pediatrics in particular. And I hope that we continue all to work to create an appropriately successful World Patient Safety theme for this year of safe care for every newborn and every child. So thank you very much.
Thank you. And thanks for having me on the show. Thanks very much.
Okay. Thanks, Peter.